I think the key in effective communication is building trust, because without trust, patients are not likely to engage in their care as effectively, which can influence patient well-being and their overall health outcomes. Building trust is, I think, crucial.
You're listening to the Oncology Nursing Podcast, where ONS Voices Talk Cancer, a resource from the Oncology Nursing Society. Through conversations with subject matter experts, we examine the important issues in oncology nursing, from new treatments to patient-centered research to advancements in clinical practice. Join us as we hear from nurses in all facets of oncology care, from bench to bedside and everywhere in between. Welcome to the Oncology Nursing Podcast. Hello, and welcome to the Oncology Nursing Podcast. I'm your host, Jaime Weimer, Manager of Oncology Nursing Practice at ONS. And today we're talking with Deb Christensen, Founder and Chief Patient Officer at the Cancer Help Desk, a nonprofit that provides personalized cancer treatment resources, about strategies oncology nurses can use when approaching difficult conversations with patients. As a reminder, you can earn free NCPD contact hours after listening to this episode and completing the evaluation we've linked in the episode notes. Thanks so much for joining us today, Deb.
Oh, I'm happy to be here. Thanks for inviting me.
Wonderful. Well, I think all oncology nurses know, if they're listening to this episode, that a hallmark of our practice is communicating with our patients and their families. And unfortunately, those conversations can often be difficult, or at least high stakes. And so we know the importance of giving good communication and being able to conduct those conversations with skill and with care. So let's start off by just identifying, how does effective communication during these moments influence treatment decisions, patient well-being, and just overall healthcare outcomes?
You know, for me, communication is key. And I think that's what oncology nurses, and as an oncology nurse navigator, that was really my key role. So I've been very interested in communication throughout my nursing career and how to make it effective. And I think the key in effective communication is building trust, because without trust, patients are not likely to engage in their care as effectively, which can influence patient well-being and their overall health outcomes. Building trust is, I think, crucial. Patients tend to be less anxious when they have a trusting relationship with their providers, with their oncology team on a whole, and they tend to follow through better on their treatment plan because they trust what you're saying. It's not easy to establish a trusting relationship when you first meet someone. But what I've found in my practice is that anticipating their needs and really listening to their story has made a world of difference in establishing that trusting relationship, and admitting if I don't know the answer to something, or if perhaps I've gotten something wrong. Going in prepared to a conversation is vital to building trust.
Absolutely. I really like that you've pulled out trust as really that underlying component. And as you said, trust is not something that will often come immediately. It really shouldn't. You need to establish that pattern of following through and doing what you say, and ensuring patients can rely on you as their advocate, as part of the care team. And so you're right, that does take time to develop. And as nurses, we often spend more time than anyone with the patients. And so we are perfectly positioned to cultivate that trust, take care of it, grow it throughout that care journey, because we know that, especially in the outpatient or the ambulatory setting, we are spending significant amounts of time with that patient, months, years. But it's important to get it right from the beginning, because if you don't build it from the beginning, or if you lose that trust for some reason, then that's a whole different battle to fight in terms of gaining that trust back. So I think so great that you brought that up from the very beginning. Along with trust, a lot of the conversations we're having with patients, we have to balance honesty and empathy for their situation. And so can you talk a little bit about that?
I used to think that empathy was a very subjective emotion, that I had to actually feel the emotion. And having not gone through a cancer diagnosis myself, sometimes patients would say, well, have you had cancer? And, to say no, I kind of felt like, well, then maybe I can't empathize with them correctly. But what I found, and what research tells us as well, is that there's intellectual empathy. And basically, intellectual empathy asks you to imagine yourself in that person's place. And we've all had challenging experiences. We just don't get through life without them. And as a result, we can generally think of a time when we might have been in a similar situation, maybe not exactly the same, but a similar situation, and garner that empathy for the patient and importantly for the caregiver too, because we genuinely want to understand somebody. Intellectual empathy really comes from listening carefully to what's being said and what's not being said, analyzing different people's perspective, knowing your own bias, and asking open-ended questions, which in writing for ONS Voice this last year on communication, I don't think there was a single episode that didn't talk about open-ended questions because they're just so important in gleaning that trust and that empathy when you really hear the person's story. I was reading an article recently and prepping for one of my articles, and it was the role of kindness in cancer care. And Katz wrote it in, I believe it was The Voice. And she described honesty as being gentle honesty. So gentle honesty is using really well chosen words and guiding the conversation. In order to do that, you have to pay attention to the people that you're talking to, pay attention to their body language, pay attention to what they're listening. One of the open-ended questions that I always use is, tell me what's the most pressing concern to you right now? Because if that's in the way, it's really hard to get past that because that's forefront in their mind and they don't, in my experience, hear as much of the conversation. So addressing what their greatest concern is at the moment, I think it shows some compassion toward them and really caring to hear where they're coming from before I just go in and deliver a message. Checklist conversation.
Absolutely. I love that because, right, as nurses, we go into that patient room or to that patient's chair and we have our list of things that we know we want to tell them or we want to educate them on or the things that we need to make sure we communicate effectively. But as you said, if they've got something pressing at the front of their mind that is going to distract them from being able to really hear or absorb what you're telling them, then it's all for naught. So it is so important for us to, we can have our checklist in our mind, but before we get to it, we need to ask them, before I go through my list, what's on yours and what can we talk about first so that we can address your most important questions first. So I love that's a great strategy.
Kind of clears the way
Right.
for the rest of the conversation to happen. One gal I was talking to, she said, well, you're just going to think this is so stupid. And I said, there's no stupid questions. And she said, I'm really afraid about losing my hair. And so we talked about that first. And then we were able to get into a discussion on chemotherapy. But that was her biggest concern first. And as it was, the chemotherapy drug, she wasn't going to lose her hair. So that kind of cleared the way there pretty easily.
Right, exactly. And so often what their pressing questions are would be included in probably what you were planning to talk to them about, especially if we're like sort of in that upfront education setting. So it's not that you wouldn't have gotten to it maybe already, but I think it does show that concern and trying to center the discussion and the care on what is most important to that patient at that exact visit. So I think that's just a great technique to lead really any conversation, whether it's a structured kind of education visit or if it's just hey, you're back for your fifth cycle, what questions do you have or what can I answer for you today? It's always a great way to start that out.
Absolutely.
So when we're communicating with patients, we have things that we want to tell them. We have news we want to share or we have information we need to share with them. But we also need to kind of balance that and respect the patient's own autonomy for what they want to know, what they need to know, and how they want to receive that. So can you talk a little bit about just incorporating the concept of a patient's own autonomy as part of the conversation?
I think that the first thing that an oncology nurse needs to do is recognize that patients have their own autonomy to make their own decisions and not go into a conversation expecting a specific outcome. So going in with the intention to do your best, but also be open to what the patient wants to do. So just really acknowledging that, I think, and having the intention to listen. So I'll give an example about a case that I went in on. The patient was there with their partner, and basically they said, the only reason I'm here is I told the oncologist I would listen to the education, but I am not having chemotherapy. I am not, never, ever going to have chemotherapy. And I said, okay, tell me about that. And so we talked about it and come to find out they had family members that had been through chemotherapy. They had some misconceptions, but just listening to that story up front, I think was helpful in building that trusting relationship. And I acknowledged that you have the right not to do chemotherapy. It is your body, but let's talk about what that would look like if you changed your mind. And what it really boiled down to was that the patient thought that if they started, they would be like basically tied to the chair. They would have to finish all cycles. and not realizing that if the side effects were intolerable or they changed their mind, that they always had that autonomy. And so helping them recognize that they have the autonomy to do that made all the difference for that patient.
That is so powerful because, again, in our role of being a communicator and sharing information with patients or reinforcing information that's been shared by other members of the care team, it does give us the responsibility to ensure that they have what they need to make that decision and use their autonomy. But we do have to make sure it's informed. And so that is really an important obligation of all members of the healthcare team, is to ensure that we're providing them with all the information that will help them to make the decision that they choose. So that is just a really important balance to strike. The story you told, when we encounter a patient that has emotion, whatever that emotion is, it can be frustration, it can be that sort of defiant posture of like, I'm not doing it, I've already decided. It could be sadness, it could be any range of emotions, whether it's the patients or even the family that's part of that patient and family component. We have to manage those emotions as we're going through these difficult conversations. And so can you talk a little bit about how we can navigate that dynamic between the patient and the family and the various emotions that will come up through the cancer care experience?
Sure. I've had a lot of experience with that because usually you are talking with caregivers as well as the patient, their family. And being a caregiver myself, it's really easy to get worked up if you don't understand what's going on or if you don't have a trusting relationship with someone. And as a caregiver, it seems like, I personally want to take control of this situation because my loved one is not getting the attention that I think that they need. And so I think acknowledging the caregiver initially, I've had the opportunity to work with a caregiver on building a program for caregivers. And he just could not stress more how when he was a caregiver for his wife, he pretty much got ignored, that he wasn't really included until at the end. And then at the end of his loved one's journey, then he was all of a sudden being asked to make these big decisions, but he hadn't been included before. So recognizing that it's stressful for family as well as for the patient and acknowledging their role in the whole process and acknowledging that it is an emotional time and how can we support you as well. I think caregivers can be your greatest advocates and great advocates for the patient and help them to understand, but not if you haven't built that trusting relationship with them. So managing, which was the original question, can be tricky. But again, trust, sensitivity, acknowledging, validating, those are all ways that I think that we can soften the family dynamics toward us. Now, when there's family dynamics between the patient and the caregiver, that can be a little trickier. I'm thinking about one couple in particular. When I first saw them at diagnosis, they were just clinging to each other. That's just a really emotional time for them. And then 6 months later, they were pretty much sitting on opposite sides of the couch. They wouldn't really talk to each other. And I think I just asked them something to the effect that I just told them, I remember when, what's different now. Then they were able to open up a little bit and talk about just the stressfulness of each other's expectations were different than they thought it should be. One thought that it was a complicated situation, but it did open the door for them to be able to express themselves, which I think was important. Our biggest foe in all of these communication strategies really is time. We just do not have the amount of time. I mean, we'd love the luxury of time to be able to sit and really get into these kind of deeper conversations with people, but we may only have 30 minutes. We may only have 15. So how do we do that? That is still a question that's out there that bears a lot of investigating. Are there techniques that can help? And there are.
It occurs to me that as you were talking through those challenging dynamics within families or within patients and their caregivers, their experience of cancer is not in a vacuum. And so they are experiencing all of the highs and the lows of just life, in addition to having to now incorporate this cancer experience into that. And so when a family or a patient comes to us and they do have intense emotions that maybe are directly related to the cancer care they're receiving, or maybe not, it could be sort of a deflection of other things that are going on in their life. And so it rings true to me to always remember, like, this is 99.9% not usually about me. It's not about me. It's not about what I've done personally. This could be related to some other experience they're having. And this is just a safe place where they can sort of let those emotions out. And so I think it's important to always try to avoid personalizing the emotions, because even if they're directed towards you, it's just because you are probably just in the wrong space, I guess, at the wrong time. But that doesn't mean we're not still critical in helping to kind of usher that patient and their family into a better place where it's not maybe something that we've done wrong, but if there is an experience that causing them this distress, we can still help hear, like you said, hear what they're saying, acknowledge the pain or the frustration or whatever the emotion is, acknowledge that it is something they're experiencing, and that in any ways that we can, but within our control, we want to help improve that situation.
Exactly.
So at what points across the cancer care continuum do you most often see these difficult conversations occur?
Well, I think they can occur at any time, really. But specifically, if we look at the cancer care continuum, there can be some at pre diagnosis or high risk patients, some difficult conversations there. Certainly at diagnosis, when treatment needs to change because it's not effective, recurrence for sure, end of life. And all of these points in the continuum have one thing in common, and that's uncertainty. That's really a whirlpool uncertainty for people. I've noticed at diagnosis, there is a lot of uncertainty. They just don't even know how they're going to cope with something like this. One of the communication strategies that I've used with people is letting them know that this is a very common emotion to experience, a sense of loss of control, uncertainty, and that in my experience that people generally, once they have a plan, the anxiety settles. So giving them kind of a guidepost, hope in the future that the anxiety will settle, because I would say 98% of the time it does. Once people gain a sense of control because they have a plan of action to move forward with. So I think that has been helpful at diagnosis. There's very interesting research out there on uncertainty and illness, and it basically can say that uncertainty can be an opportunity, which seems like a bit of a twist, right? But I was talking with a gentleman who was going through a treatment change. He was quite concerned about it. And I said, well, could you possibly see this as an opportunity? It's a new treatment. The cancer cells haven't seen this. Did you see it as potentially an opportunity to treat the cancer differently or maybe different results? He hadn't really thought about that before, but he liked that. He liked that idea of like, well, I don't know if it will help, but I don't know that it won't. That's what he said. I don't know that it won't either. So that kind of helped change his perspective there. And then certainly end of life is very delicate conversation and one that takes skill and practice. There's some great training out there for having those types of conversations. I mean, I've heard them at Congress before. So it's a delicate topic, but certainly one that nurses, if they're prepared, need not shy away from.
And I love that you've highlighted some great time points that are often, whether it's you might even be having these conversations if you work more in that prevention, high risk clinic type of environment, you might be having these discussions with people who don't technically have a cancer diagnosis, but now their outlook on the future is, as you just mentioned, with that heightened risk of the unknown of if it will happen, when it will happen. And I just really like how you pulled all of those together to center on that feeling of uncertainty and not knowing what to expect or not knowing what comes next. And I think for oncology nurses and for myself, I know it's, if you do this long enough, it becomes second nature. Of course, we'll do next as a CT scan, or we'll get blood work, or we'll get your first cycle in 2 weeks. That all feels very routine for us because we do it all the time, but we can't become complacent to forget that hopefully for every patient that we see, this is their first time. And so it is brand new and it is scary. Or as with the other story that you shared of they come to that experience assuming it's going to be like what they heard or saw or know from another person. And that can be an equally dangerous expectation because it might just be very inaccurate. They might have a completely different course ahead of them. And you want to make sure that they're not entering into their treatment plan, assuming it's going to be exactly what they experienced or observed with a friend or family. Because again, that could potentially erode that trust when they're going in with one kind of expectation and suddenly it's not at all that. So as you said, it's that opportunity to level set with them, find out what they do know or what they are expecting, or if they are expecting anything. And then you can start to redirect if some of their expectations are not in line with what their treatment will bring for them, or fill in those gaps if they are completely unsure of what to expect, and you can guide them into giving them those steps to look forward to. Here's the steps in the plan. as you said, giving them just that sort of roadmap of here's the big picture, here's where we're headed, and along the way, here are some stopping points that we will get to, can give them a little bit more understanding and control over that sort of short-term treatment plan for them.
I couldn't agree more.
You talked, and I really liked that you just briefly mentioned this. So I'm hoping we can go a little bit deeper. The notion of communication, having these conversations with patients, and equally important, listening and that skill of active listening. These are skills. These are things that, while some of us might have natural talent to do these things, there is methodology, there is training, there is additional learning that can be acquired so that you become very skillful in this. And so can you talk through what are the evidence-based models or techniques that oncology nurses can use to improve their skill in having these difficult conversations?
So, in the article that I mentioned that I was reading about the role of kindness in oncology care, the models that they talked about the most were spikes, which most nurses have heard. That's a mnemonic, basically. I particularly like that one, and the reason I like that one is because it does address emotions. The E in spikes is for emotions. An easier one to remember is ask, tell, ask. Asking an open-ended question, giving the information, and then asking again to make sure that you have communicated successfully. So if I can, I'd like to expand a little bit on spikes because I think it is very apropos to what we're talking about. So the S in spikes really is about the setting. And in doing chemotherapy education, we really advocated in the facility that I was in that we have a special room to do that in, that was quiet, that had the resources at hand that we needed. If the patient and family couldn't come in and it had to be done in the chemotherapy room, it was an absolute disaster. There was just too much going on, too much distraction, and it just wasn't conducive to learning. So I think the setting is really, really important, especially when you're having these challenging conversations. Always checking for understanding is that perception. What is the patient perceiving? What is the caregiver family perceiving? Are they understanding you correctly? And you mentioned earlier being respectful of what people want to know, because sometimes they don't want to know specific things. And I had one case where the patient did not want to know any prognosis or anything because they felt like that would really drag them down, but they were fine if their loved one knew. That was a bit tricky. We want to provide knowledge. The K in spikes is knowledge. So providing that information in a factual way, an honest way, again, that genuine honesty and balancing that honesty with the empathy. So interestingly, young adults say that, and the research tells us that young adults say that they want the clinician to be calm and to be honest at the same time being respectful of their feelings. And so you really have to be on your toes. They're watching, paying attention. Again, watching body language. And then the E is for emotions, addressing the emotions. And I think oncology nurses need to be aware of their own biases and their own emotional state when they're going into these emotional conversations, these difficult conversations. They really need to be, and you might not always be the right one for the conversation. I think that's an important thing to note too, and be able to admit that you may have had a personal life experience that just is not going to allow you to get around a bias or an emotional reaction to the conversation. And so you might not be the right one.
I think that's so important. And I really value having that mnemonic, that tool to, even if you're not about to have a conversation, make one up, make up a case study for yourself to practice what those steps would entail and how it can be methodical in terms of what you plan to say. Obviously, you don't want to sound like you're reading a script or you're not robotic, but when you do think of, okay, if I were to say a sentence or two to address each letter of the spikes model, then you would see that your delivery would be pretty comprehensive because you're having that awareness of how you need to present the information, how they want to receive the information. It just gives a good roadmap on how to deliver that news. And as I said, it's a skill that requires practice. Oncology nurses have a lot of challenging conversations to have. And so there's plenty of opportunities for practice. But before you even are having that first conversation with a patient or a family, I think it's great. It'd be a great exercise to do with your colleagues or your team. Think of some scenarios that are common for your department or your unit and have some of that role playing of just getting comfortable of having those conversations so that the first time you are having that directly with the patient, it doesn't feel like the first time. It feels like, okay, I've done this a few times. And so I kind of know which pieces to include and kind of how to move the conversation forward.
I totally agree.
And so I think another component of this is tailoring the conversation, not only, of course, to the individual, but then also just being aware of different populations. And while we wouldn't want to assume that any single group all wants the same thing, I think there are some themes that emerge when you're thinking of different populations of patients, such as whether it's pediatric patients and their parents, adolescent patients, the young adult or older adult population, or individuals that have developmental disabilities. So can you maybe expand a little bit on just how you would approach tailoring that communication for various populations?
Yeah, I'll try.
Right?
Yeah. So, with parents of children, this wasn't something that I had a lot of experience with prior to founding Cancer Help Desk and working in the nonprofit sector, because in the facility that I was previously at, we didn't have pediatric patients. And what I've noticed in the pediatric community is that parents, they celebrate every small milestone. And in the research, it tells us that they want to celebrate those. And so, not to shy away from that, to celebrate with parents. Every small milestone is a hopeful one. There are some conditions where it is just so tragic because based on science, that the prognosis is not good. But I've always felt like if you can help someone find joy and peace in the moment, then that moment was made better. Life is a series of moments. That's kind of how I get through that piece of it. I think I mentioned that the AYA population really wants people to remain calm, no drama, is what the research says. Another thing that it said was to read the room before delivering bad news. And I think that's something that we could do with any conversation, to read the room, take a moment, pause to check in with people's, again, body language. The couple that was sitting apart on the couch, well, that was pretty obvious that there was something going on there. So reading the room. I think with adults and with older adults as well, that we need to really respect their autonomy at that point. They can make their own decisions. One of our social workers got GBM, glioblastoma. They chose not to treat it at all, which was devastating for the team, very devastating for the team. But it was very important that we respect their autonomy, in that they were an adult and they could make the decision that they felt was best for them. Communication strategies with older adults. So I've had some experience with this of recent with my parents, taking them to appointments. And it just is very difficult when someone talks down to your loved one, like they're a little child or something like that. So just making sure that you communicate effectively and not making an assumption about the person sitting across from you. Also, with our older adults, making sure that you're looking directly at them, that they can see your mouth move, and that you're not shouting at them. If they ask you to speak up, that's one thing, but shouting at them because you assume that they can't hear can hinder building trust and communication. And then with the mentally handicapped, that's really tough. I don't have a lot of experience with that. I kind of went to the research to see, and I think it's really up to the healthcare team to determine if they need a surrogate. I can recall one situation where there was a Down syndrome patient with, I believe it was leukemia, and the patient's family really wanted to treat it and did so. And it was a much better scenario than I had imagined it would be, having a Down syndrome son myself. It was a lesson to me. Just be aware of the differences in these different populations and using some communication strategies that have been shown to be more effective with them.
Absolutely. That's exactly where my mind was headed of that. It's just very important. And I'm sure for many nurses listening, you probably deal with it consistently, maybe with one or two of these populations. Most nurses aren't seeing one pediatric patient and the next is an adult. There's some partition there. But I think that the point to take home is that reset yourself with every patient and craft your communication style and approach to meet the patient where they need, knowing that it might be different from one room to the next, one chair to the next, but that we do have to ensure that we're providing the communication in the style that meets the patients and their families so that they can hear what we need to share with them, learn the education we're providing, and come away with that with an understanding of kind of what to expect. Well, Deb, thank you so much. We've shared so much information today that I think will really be helpful as nurses continue to navigate these difficult and challenging conversations throughout their careers. Before we close our episode today, I'd like to always run through a few quick fire questions that will probably touch on some themes we've already covered, but help us to summarize a few of those points as well. So to start that off, How can oncology nurses evaluate their implicit bias surrounding difficult conversations in cancer care?
I would say self-reflection, taking time to reflect on the conversation itself, on the people that you're going in to talk to, and then just reflecting in quiet moments with the intention of finding those biases. And then you, of course, you can ask others, what have you noticed? And be open to their advice.
I like that because sometimes we don't see it ourselves, and sometimes we need it reflected back to us so that we can be really aware if something felt like it kind of missed the mark. What are some common misconceptions about difficult conversations in the cancer continuum?
I think the one size fits all, you couldn't go in with spikes every time and have it work. Again, read the room, understand, look at the people that you're talking to, take a pause. And I think the fact that we think difficult conversations are always difficult because sometimes they're not. It's a difficult situation, but the conversation itself can be very rewarding if you're prepared.
What's something about this topic that's not often discussed, but you wish people knew more about?
I would say health literacy, only because, if we've done a lot of the things that we've talked about in the podcast today, I haven't talked about health literacy. And in health literacy, using universal precautions, which I love. Universal precautions of just assuming that everyone that you're talking to is at risk of not understanding health information and tailoring that information to a level that most anyone could understand. And I think nurses can do this so well and are in such a great position to be able to leave out the medical and explain, or use the medical term and explain the medical term.
I always felt like one of my primary jobs was translator to help turn the medical complex jargon into something meaningful. And so you're absolutely right. I think nurses do that extremely well. I definitely agree with that for sure. What additional training or education do oncology nurses need to further prepare them for doing this difficult conversation better for their patients?
Well, experience helps, precepting helps. If there is someone that does it really, really well, listening, observing what techniques that they use can be helpful. I did take interprofessional communication curriculum, I believe it is, through the City of Hope. And that is a course that I would encourage anyone to take. It is, I don't believe they charge for it. You just have to get on a wait list through City of Hope, but it is just wonderful. They have some wonderful scenarios and role play on how to communicate in oncology care. Center to Advance Palliative Care, I believe that's CAPC, is another great place to learn about how to have those difficult conversations.
That's wonderful. Are there any additional resources that you would share, maybe for patients even, or providers that want to learn more?
Well, I always go to ONS resources. They type in, courses or just different, I really don't, Jamie. For patients, I would just give them support tools for the journey, not so much resources for learning, how to communicate. But I might ask them directly, how do you learn best?
I think that's great. And I think you gave some great examples for nurses to explore more to help improve their own skill and to help improve the skill of their entire team. Because as we all know, patients will interact with a variety of us on the healthcare team throughout their journey, and everyone will be best served if we all can elevate our skill at having these conversations. So I think those are some great recommendations. Thank you again, Deb. You have just provided some great information, some great tips to get us all started and thinking more critically about how we have these conversations with patients. Do you have any final comments to share with our listeners today?
I would just encourage nurses to enter those conversations with the intention of doing their best. And I think they will.
Oh, well, thank you so much.
Thank you for having me.
Thank you for listening to the Oncology Nursing Podcast. Tell us about your favorite part in this episode by leaving a review wherever you download your podcast. For more resources and information about oncology nursing, visit us at ons.org or voice.ons.org. The ideas and opinions shared in this episode represent those of the guest and not necessarily ONS.